wrist complex is utilized frequently in the performance of activities of daily living, as well as in specialized tasks. Physical abnormalities leading to difficulties in writing or picking up small objects, to cite only a few examples, are extremely frustrating for the patient. Inspection. Inspection of the hand and wrist region should commence as soon as the examiner sees the patient. The cognizant examiner can gain a lot of information simply by shaking the patient's hand. Note the attitude and posture of the hand and wrist when taking the patient's history. Look for any guarding or protected movement versus the spontaneous smooth motion that the normal patient will utilize. It is important to determine at the beginning which is the patient's dominant hand, and if they consider themselves ambidextrous. In order to properly examine the hand and wrist, the entire upper extremity must be exposed and examined, and at all times compare one region to its counterpart in the opposite extremity. Observe the patient performing a few simple tasks, such as writing their name, picking up both large and small objects off the table, and in performing rapid alternating movements such as tapping the fingers on the table. Note that in the rest position, the metacarpal phalangeal and interphalangeal joints assume a position of flexion. Beginning on the dorsum, assure that all digits, thumb, index, middle, ring, and little fingers are present. Ask the patient to separate the fingers and note the web space. Inspect the knuckle or metacarpal phalangeal joint region. Note in the normal patient the prominence of the joint region with depressions or valleys between the metacarpal phalangeal joints. Swelling in the metacarpal phalangeal joints may actually decrease their prominence as the valleys between them disappear. Instruct the patient to clench the fist and compare the alignment of the metacarpal phalangeal joints on both hands. Next, observe in turn the proximal interphalangeal joints and the distal interphalangeal joints of the fingers and the interphalangeal joint region of the thumb. Any redness or swelling in these regions should be noted by the examiner. Observe the nails of all the digits, as they may provide clues as to previous trauma or even cardiovascular problems. More proximally, inspect the dorsal aspect of the metacarpal region and the wrist region, looking for deformity, discoloration, swelling, or scars. Next, observe the palmar surface of the hand and wrist region, noting the creases in the skin. In the fingers, note the distal interphalangeal crease, the proximal interphalangeal crease, and the palmar digital crease. In the palm, the distal palmar crease denotes the level of the metacarpal phalangeal joints. The proximal palmar crease lies approximately 1 centimeter proximal to the distal palmar crease, and the thenar crease outlines the thenar eminence. Observe the regions of the thenar and hypothenar eminences, noting any difference between the two hands suggesting muscle atrophy. Observe the shape of the palm, and from the side note its saucer-like shape with the central depression. Palpation. Bony landmarks. At the wrist level, localize the radial styloid and on the ulnar border, the ulnar styloid. Note that the tip of the radial styloid is approximately 1 centimeter more distal than the tip of the ulnar styloid, and this anatomic finding is important when assessing the reduction of a Colles fracture clinically. Note in the Colles fracture there is shortening of the radius with respect to the ulnar styloid. Follow the radius proximally into the forearm. Follow the distal aspect of the radius dorsally and locate the bony prominence known as Lister's tubercle. The subcutaneous surface of the ulna can be palpated all the way up to the tip of the olecranon process. The individual bones of the carpus cannot be palpated in their entirety, but the examiner must be aware of their approximate location so that localized tenderness can be correlated. These are as follows. Beginning on the radial aspect of the wrist, the scaphoid or navicular. Progressing ulnarwards in the proximal row is the lunate and trichetrum. The trapezium and trapezoid, capitate and hamate comprise the bones of the distal row of the carpus. On the volar aspect, palpate the pisiform, which overlies the trichetrum. Anatomical snuff box. The anatomical snuff box, just distal to the radial styloid, is outlined on the radial aspect of the wrist by instructing the patient to bring the thumb to the side and back. The extensor pollicis longus tendon stands out dorsally, and on the volar aspect, the tendons of the extensor pollicis brevis and abductor pollicis longus are noted. Scaphoid. The floor of the snuff box is occupied by the scaphoid bone. While deviating the wrist to the ulnar side, the scaphoid can be palpated in the depth of the anatomical snuff box. The scaphoid is the carpal bone most commonly fractured. Trapezium. By having the patient flex and extend and rotate the thumb, the region of the trapezial first metacarpal joint can be localized. This region must be thoroughly examined for deformity and tenderness, and degenerative osteoarthritis in this joint is not uncommon. Capitate. Localize the third metacarpal on the dorsal aspect of the hand and follow it proximally to its base. The examining finger then falls into a depression, and this represents the location of the capitate bone. Lunate. In the same line more proximally is the lunate bone, which is interposed between the capitate and the distal articular surface of the radius. Trichetrum. Place the wrist in radial deviation and just distal to the ulnar styloid, the position of the trichetrum is localized. Hamate. More distally, articulating with the base of the fourth and fifth metacarpals, the region of the hamate bone is localized. Metacarpals. On the dorsal surface of the hand, palpate in turn the first, second, third, fourth, and fifth metacarpals, noting any tenderness or deformity. Pisiform. With the volar surface of the hand and wrist facing the examiner, return to the tip of the ulnar styloid on the dorsal ulnar aspect for the purpose of orientation. Just distal to the ulnar styloid on the volar aspect, palpate the pisiform bone. Hook of the hamate. The hook of the hamate is covered by the muscles of the hypothenar eminence and is difficult to palpate. However, its location, distal and radial to the pisiform, should be noted, and this region carefully palpated. Return to the dorsum of the hand and carefully palpate the regions of the metacarpal phalangeal joints, the interphalangeal joint of the thumb, and the proximal and distal interphalangeal joints of each finger, noting any tenderness or bony deformity, such as in this patient with pronounced Heberden's nodes indicating osteoarthritis of the distal interphalangeal joints. Palpation. Soft tissues. The soft tissues palpable on the dorsum of the wrist are comprised of the tendons and synovial sheaths of the extrinsic extensor muscles to the wrist and hand. Diffuse swelling on the dorsum of the wrist and hand, as seen in this patient with rheumatoid arthritis, is due to synovial inflammation of the dorsal tendon sheaths. Localized swelling is usually secondary to a ganglion, or more rarely synovial thickening involving only the tendon sheath or sheaths of a single compartment. Beginning on the radial aspect of the wrist, the first compartment contains the abductor pollicis longus and the extensor pollicis brevis tendons. These tendons were previously identified when localizing the anatomical snuff box. Palpate the tendons distally into the hand region and proximally into the forearm. Tenderness in this region may be indicative of inflammatory synovitis, commonly known as de Quervain's tenosynovitis. Also note any crepitations produced during movement of the tendons within the compartment by asking the patient to bring the thumb out to the side and backwards. Palpating crepitus also suggests synovial inflammation within the first compartment. The second compartment contains the extensor carpi radialis longus and brevis tendons. Locate Lister's tubercle on the dorsal aspect of the radius, and while palpating the region to the radial side of the tubercle, instruct the patient to make a fist. The tendons of the extensor carpi radialis longus and brevis are palpated. Note that when the patient is asked to make a fist, the wrist goes into extension and radial deviation, which increases the grasp strength. The extensor pollicis longus tendon occupies the third compartment. Instructing the patient to extend the thumb highlights the extensor pollicis longus tendon, which can then be palpated proximally as it passes on the ulnar side of Lister's tubercle, and distally as it courses into the thumb. The fourth compartment is located just ulnar to the third compartment and contains the tendons of the extensor digitorum communis and the extensor indicis proprius. The tendons can be highlighted on the dorsal aspect of the hand by asking the patient to extend the fingers, and then they can be followed up into the hand and wrist region. By maintaining the lateral fingers in the flexed position, ask the patient to extend the index finger, and the extensor indicis proprius tendon can be highlighted alone. The fifth dorsal compartment contains the tendon of the extensor digiti minimi, which can be identified by having the patient extend the little finger while keeping the other fingers in the flexed position. As this tendon is followed proximally, it crosses the dorsal aspect of the distal radial ulnar articulation. This joint should be assessed for tenderness and synovial thickening. Also test the stability of this joint by attempting to push and pull the ulna forwards and backwards with respect to the radius. The extensor digiti minimi is prone to rupture at the level of the ulnar styloid, either secondary to friction caused by a dorsal dislocation or from synovitis arising from the distal radial ulnar joint in the patient with rheumatoid arthritis. The sixth or last dorsal compartment contains the extensor carpi ulnaris tendon, which is accentuated by asking the patient to push ulnarward and extend while applying resistance, and is palpated as it courses across the dorsal ulnar aspect of the wrist. Volar aspect. Palmaris longus tendon. Instruct the patient to flex the wrist against resistance while palpating the volar aspect of the wrist. In the midline, the palmaris longus tendon, if present, is observed. In approximately 13% of patients, the palmaris longus tendon is absent unilaterally or bilaterally. Radial artery. Locate the radial artery on the volar radial aspect of the wrist. Flexor carpi radialis. On the ulnar aspect of the radial artery, the tendon of the flexor carpi radialis can easily be palpated by having the patient flex the wrist against resistance. Flexor carpi ulnaris. The flexor carpi ulnaris tendon can be located and palpated on the volar ulnar aspect of the wrist by having the patient flex and ulnar deviate the wrist against resistance. Thenar eminence. On the palmar aspect of the hand, the thenar eminence is composed of three of the intrinsic muscles of the thumb: the abductor pollicis brevis, the opponens pollicis, and the flexor pollicis brevis. The thenar eminence must be carefully palpated. Hypothenar eminence. The hypothenar eminence is composed of the abductor digiti minimi, the flexor digiti minimi brevis, and the opponens digiti minimi. This region is located and palpated on the ulnar aspect of the palm. Palmar aponeurosis. On the palmar aspect between the thenar and hypothenar eminences, palpate the region of the palmar aponeurosis. Note any thickening or nodularity in this region, as in this patient with contracture of the aponeurosis or Dupuytren's contracture. Extrinsic flexor tendons. Although the long flexor tendons to the thumb and fingers are not individually palpable in the palm region, carefully palpate the area on the volar aspect of each metacarpal phalangeal joint while asking the patient to flex and extend the thumb and subsequently each of the fingers. A palpable and often audible snapping indicates triggering of the flexor tendon, and careful palpation may reveal an apparent nodule of the flexor tendon indicative of either a trigger thumb or a trigger finger. Synovial effusions. It is essential to examine each metacarpal phalangeal joint and each of the interphalangeal joints to detect any effusion or synovial thickening. To assess the metacarpal phalangeal joint, slide the index finger and the thumb along the dorsal radial and dorsal ulnar aspect of the proximal phalanx towards the flare at the base. As the index and thumb strike the head of the metacarpal, the examiner will appreciate a depression at the level of the metacarpal phalangeal joint. Failure to appreciate this depression suggests an effusion or synovial thickening. An effusion can be detected by ballottement of a fluid wave back and forth between the thumb and index finger. To assess swelling or an effusion at the proximal and distal interphalangeal joints, place the thumb and index finger along the ulnar and radial aspects of the joint respectively. With the other hand, place the thumb under the volar aspect and the index on the dorsal aspect of the joint, and compress the sides of the joint. If fluid is present, the dorsal index finger will be felt to rise away from the joint. Range of motion. Both active and passive motion at both the wrist and each of the multiple thumb and finger joints in the hand must be accurately assessed, and the range of motion measured by a goniometer. Wrist motion. At the wrist level, the following ranges of motion must be assessed: flexion, extension, radial deviation, ulnar deviation, pronation, supination. Fingers and thumb motion. One must assess the possible ranges of motion at each joint. Beginning with the finger metacarpal phalangeal joints, the following ranges must be assessed: flexion, extension, abduction, adduction. At both proximal and distal interphalangeal joints of the fingers, assess the range of flexion and extension. In the thumb, begin at the carpal metacarpal joint and assess palmar abduction and adduction, and opposition, or the ability to bring the thumb out of and across the palm and touch each of the fingertips. At the metacarpal phalangeal joint, assess flexion or transpalmar abduction and extension or radial abduction. At the interphalangeal joint of the thumb, assess the range of flexion and extension. Wrist. Range of motion active. Place the wrist in the neutral position, that is, in line with the forearm, and instruct the patient to flex the wrist and extend the wrist. The normal range of flexion is approximately 80 degrees, and extension approximately 70 degrees. Radial ulnar deviation. With the patient's hand and forearm supported on the table, place the hand and wrist in the neutral position and instruct the patient to rotate the hand towards the ulnar side and then towards the radial side. Ulnar deviation of approximately 30 degrees is somewhat greater than radial deviation of approximately 20 degrees. Pronation, supination. It must be remembered that pronation and supination do not take place solely at the wrist, but are also dependent upon motion at the proximal radial ulnar joint and also on the ability of the radius to rotate around the stationary ulna. Hence, pathology more proximally in the forearm or elbow can limit pronation and supination. With the elbows maintained at the patient's side to limit any shoulder motion and the palms facing each other, instruct the patient to turn the palms towards the floor, pronation, and towards the ceiling, supination. By asking the patient to grasp a pencil in each hand, accurate measurement of pronation, approximately 85 to 90 degrees, and supination, approximately 90 to 95 degrees, can be made. Fingers. Motion at each finger must be assessed at the metacarpal phalangeal and interphalangeal joints. Flexion. Start by assessing finger motion globally by instructing the patient to slowly make a fist. Note that all four fingers flex together and touch the palm in the region of the distal palmar crease. For extension, instruct the patient to slowly open the hand and note that the four fingers smoothly come out of the palm together. With the fingers fully extended and the palm downwards, observe the hand from the side and note that the fingers go into hyperextension at the metacarpal phalangeal joints. Next, check flexion and extension at each of the finger metacarpal phalangeal joints in turn. Abduction, adduction. Abduction is the ability to move the fingers away from the midfinger, and adduction towards the midfinger. Starting with the fingers opposed to each other, instruct the patient to spread the fingers apart, noting in the normal approximately 20 degrees between each finger. Adduction is the ability to bring the fingers back into apposition. Interphalangeal joints. Next, assess flexion and extension at the proximal and distal interphalangeal joints of each finger. The examiner must stabilize the phalanx proximal to the joint being tested. Note that at the proximal interphalangeal joint, the motion is from full extension, or 0 degrees, to approximately 110 degrees of flexion. At the distal interphalangeal joint, motion is from slight hyperextension, or minus 10 degrees, to approximately 80 degrees of flexion. Thumb. Palmar abduction, palmar adduction. With the palm facing upwards, instruct the patient to lift the thumb up away from the palm. This motion is called palmar abduction, which occurs at the carpal metacarpal joint of the thumb. The angle measured between the index and the thumb is approximately 70 degrees in the normal. Adduction is the ability to return the thumb to the resting position. Extension, flexion. With the palm facing upwards, instruct the patient to extend or abduct the thumb radially, and normally an angle of 50 degrees is obtained between the thumb and the index finger. Note that in performing this motion, extension is occurring at the metacarpal phalangeal joint and radial abduction at the carpal metacarpal joint. Next, stabilize the first metacarpal and test flexion of the metacarpal phalangeal and interphalangeal joints, noting approximately 50 degrees of flexion of the metacarpal phalangeal joint and 90 degrees of flexion at the interphalangeal joint. Opposition. Opposition of the thumb is tested by instructing the patient to bring the thumb out of the plane of the palm and across to touch each of the fingertips in turn. Range of motion, passive. If any restriction of motion has been noted during active assessment, the examiner must gently test each joint or joint complex passively in an attempt to determine the cause of the decreased range of motion. Wrist. Flexion 80 degrees, extension 70 degrees. Stabilize the patient's forearm and gently grasp the patient's hand with your other hand. Move the wrist through flexion and into extension, noting the range of passive motion. Passive wrist extension can also be assessed bilaterally by having the patient place the palms together in the prayer position and attempt to bring the elbows up as high as possible. Note in the patient with decreased extension on the right wrist, the right elbow cannot be lifted as high as the left. To test flexion, instruct the patient to place the back of the hands together and bring the elbows down as far as possible. Decreased flexion on the patient's right wrist is manifest by the right elbow remaining higher than the left. Ulnar deviation, radial deviation. Stabilizing the forearm, assess ulnar deviation approximately 30 degrees and radial deviation approximately 20 degrees at the wrist. Supination, pronation. With one hand, gently grasp the patient's lower humerus and maintain the arm at the patient's side. With the other hand, hold the patient's hand in the handshake position and rotate the patient's palm towards the ceiling, supination, and towards the floor, pronation, noting normally approximately 90 degrees of motion in each direction. Fingers, metacarpal phalangeal joints. Stabilize the metacarpal with the thumb and index finger, and with the other hand gently grasp the proximal phalanx with the thumb and index finger. Flex and extend the metacarpal phalangeal joint, noting approximately 90 degrees of flexion and 30 to 45 degrees of extension beyond the neutral position. Assess the other metacarpal phalangeal joints in a similar manner. To test for abduction and adduction at the metacarpal phalangeal joints, place the patient's palm on the table so that the metacarpal phalangeal joints are in the neutral position. Passively abduct and adduct the index, ring, and little fingers in turn from the mid finger. Then have the patient spread the fingers and note that the mid finger can be passively abducted approximately 20 degrees from the midline, both towards the index and the ring fingers. Interphalangeal joints. To assess passive flexion and extension at the proximal and distal interphalangeal joints, stabilize the phalanx proximal to the joint with the thumb and index finger, and gently grasp the phalanx just distal to the joint with the thumb and index finger of the opposite hand. Assess flexion and extension at the proximal interphalangeal joint, noting approximately 100 degrees of flexion and no extension beyond the neutral position. At the distal interphalangeal joint, approximately 50 degrees of flexion and 20 degrees of extension beyond the neutral can be obtained. Thumb. Flexion, extension. Flexion and extension at both the metacarpal phalangeal and interphalangeal joints should be assessed. Stabilize the bone proximal to the joint being tested and grasp the bone distal to the joint being tested between the index finger and the thumb. First test the metacarpal phalangeal joint, noting approximately 50 degrees of flexion and extension to the neutral position. At the interphalangeal joint, there is approximately 90 degrees of flexion and 20 degrees of extension from the neutral or straight position. Thumb carpal metacarpal joint. To test passive motion at the carpal metacarpal joint, stabilize the carpus between the thumb and index finger in the region of the anatomical snuff box. With the other thumb and index finger, gently grasp the first metacarpal and test palmar abduction by bringing the thumb up away from the palm. Assess opposition by attempting to bring the first metacarpal out of and across the palm towards the base of the little finger.